Hi everybody, welcome to my YouTube channel Dr. Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurophysician from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very interesting topic, the pharmacology of epilepsy, the indispensable concepts. The pharmacology of epilepsy, the indispensable concepts. To understand the indispensable concepts of anti-epileptic drugs, we need to understand certain basics. First, what is it which causes seizures? The pathogenesis of seizures. Seizures is a delicate balance between, at one end of the spectrum, excitation, at the other end of the spectrum, inhibition. So when the neuronal activity, there's an excitation of the neuronal activity or an inhibition of the neuronal activity, excitation of the neuronal activity causes seizures. When the inhibition of the neuronal activity is inhibited, that also causes seizures. So the anti-epileptic drugs are the drugs which can bring down the seizures by two mechanisms. One, decreasing the excitability or increasing the inhibition. So what are all the mechanisms which increase the excitation, the neuronal excitation, and thus causing seizures? First is the increased sodium channel and calcium channel activity. Increased sodium channel and calcium channel activity. Second is excitatory synaptic activity. And third, very important, is increase in the excitatory neurotransmitter, the glutamate. So the glutamate can be increased per se or through synaptic vesicle protein binding. So these three are the mechanisms which increases the excitability of neuronal tissue and thus causing seizures. So what are the mechanisms which cause inhibition of neuronal activity, and thereby when we disinhibit and therefore when we target these mechanisms, it causes inhibition of seizures? One, when there is a decrease in GABA activity. Gamma aminobutyric acid is a neuroinhibitory substance. So when there is a decrease in the inhibitory neurotransmitter gamma aminobutyric acid, it increases the chances of seizures. The inhibitory synaptic activity decrease will decrease the seizure potential. So when the inhibitory synaptic activity, when there's an inhibition, again it causes the seizure activity. Second, the potassium channel activity when there's a decrease. So these are all the mechanisms: GABA, inhibitory synaptic activity, potassium channel activity. These all decrease the chances of person getting seizures. So when we enhance these mechanisms of action, again seizures can be decreased. So either giving antagonists to excitatory substances or agonists of inhibitory substances decreases the seizures. So antagonists for excitation, sodium channel, calcium channel blockers, decreasing the exciting synaptic activity and decreasing glutamate activity. So we have to decrease the excitation and then increase the inhibitory mechanisms, like increase in GABA, increase in the inhibitory synaptic vesicle, and increase in the potassium channel activity. So it's a delicate balance. So having understood the basic principles of excitation and inhibition of neuronal activity, now we can see all the anti-epileptic drugs, the classification of the anti-epileptic drugs according to the mechanism of action. So once we have understood this diagram, it now becomes very easy. So the anti-epileptic drugs act in one of these 6 ways. One, it could be sodium channel blockers, that is Phenytoin, carbamazepine or sodium valproate. Second, it can be calcium channel blockers, that is ethosuximide. And then the drugs which enhance GABA level, which is an inhibitory substance like benzodiazepines and phenobarbital. The drugs which decrease the glutamate activity like lamotrigine. And the drug which acts on the synaptic vesicle protein binding, altering the neurotransmitter release like levetiracetam and brivaracetam. And drugs which are potassium channel openers like retigabin. So all the anti-epileptic drugs fit into one of these categories. The sodium valproate has got many mechanisms of action and therefore it's a broad spectrum anti-epileptic drug. It can be a sodium channel blocker, it can act on the calcium channels and therefore it is used even in absence epilepsy. So sodium valproate is a broad spectrum anti-epileptic drug. So anti-epileptic drugs acts through these 6 mechanisms. Now, having understood the mechanism of action of anti-epileptic drugs, I want to talk about the most indispensable concepts of anti-epileptic therapy. The first and foremost is we need to understand a concept called as hepatic enzyme inducing drugs, hepatic enzyme inhibiting anti-epileptic drugs. There are anti-epileptic drugs like phenytoin, carbamazepine and phenobarbital, which are hepatic enzyme inducers. So when they induce hepatic enzymes, the hepatic enzymes metabolize the drugs which act through this pathway, like oral anticoagulant warfarin. So when we give warfarin along with hepatic enzyme inducing drugs like phenytoin, phenobarbital or carbamazepine, they induce hepatic enzymes and therefore drugs which get metabolized by the hepatic enzymes, they get metabolized fast and their duration of action reduces. Example, oral anticoagulants. So when we give oral anticoagulants with the hepatic enzyme drugs, we need to know this principle and therefore we have to increase the dose of oral anticoagulants or vitamin K antagonists like warfarin because its duration of action is shortened. As we have hepatic enzyme inducing drugs, we have hepatic enzyme inhibiting anti-epileptic drug. The most common example for this category is sodium valproate. Sodium valproate is a hepatic enzyme inhibiting drug and therefore it inhibits hepatic enzymes and therefore drugs which get metabolized by hepatic enzymes, their action can get prolonged. So we have to shorten the drug which gets metabolized by hepatic enzymes when we give sodium valproate. The classic example is sodium valproate and lamotrigine. When we give sodium valproate, it inhibits hepatic enzymes, therefore lamotrigine does not get metabolized fast. There's a slow metabolism of lamotrigine, so its duration of action is prolonged. This is very important because when we give sodium valproate along with lamotrigine, we have to decrease the dose of lamotrigine because its duration of action is prolonged. And the third important point is that there are anti-epileptic drugs which do not get metabolized by hepatic enzymes. They neither induce nor inhibit the hepatic enzymes. Classic examples levetiracetam and brivaracetam. Because of this big advantage, they are preferred anti-epileptic drugs. They do not have side effects. They do not have side effects or interaction with other drugs because they neither induce hepatic enzymes nor inhibit hepatic enzymes nor get metabolized by hepatic enzymes. So levetiracetam and brivaracetam usually do not have side effects. Levetiracetam has got a small side effect of causing behavior abnormalities. That is also less seen with brivaracetam. And brivaracetam has got 15 to 30 times more affinity for synaptic vesicle protein as compared to levetiracetam, and therefore slowly brivaracetam is scoring over levetiracetam. Another important concept is the concept of early status epilepticus treatment and the late status epilepticus treatment. With the increasing duration of action of status epilepticus, there is a shift of GABA receptor mediated inhibition to NMDA glutamate receptor excitation. So with increasing duration of status epilepticus, initially It is because of GABA, but at a later point of time towards the end it becomes glutamate antagonist. So initially the GABA levels are decreased in the early part of status epilepticus, and therefore we have to give GABAergic drugs like lorazepam, but it gets shifted to glutamate activity towards the later part of the status epilepticus, and there's an increase in the NMDA glutamate activity in the later part of status epilepticus, and therefore we give NMDA glutamate antagonists like ketamine. Very important point. That's why lorazepam is very useful in early status epilepticus. It is not useful in later part of the status epilepticus or late status epilepticus, because the late status epilepticus has nothing to do with GABA, it is to do with glutamate. There's an excess of glutamate, that's why we give ketamine, a glutamate antagonist. So early part of the status epilepticus is because of the decreased GABA level, and therefore we give GABAergic drugs like lorazepam. But the later part of status epilepticus is because of the increased glutamate level, and therefore we give glutamate antagonist like ketamine, NMDA glutamate antagonist. Phenytoin. Next important concept is phenytoin. Phenytoin follows a non-linear kinetics. It is not a linear kinetics, non-linear kinetics, and therefore after a certain level, when we increase the dose of the phenytoin, there's a disproportionate increase in the serum half-life and therefore the side effects. And therefore, we have to increase the dose of phenytoin only to a certain level, beyond which there is an unacceptable side effects. For example, phenytoin, if you give 300 to 400, its action also increases. 400 to 500 also, its action still increases. But 500 to 600, it increases disproportionately when it comes to 600 milligrams. Not only its action increases disproportionately, along with it, there are a lot of side effects. So phenytoin, we have to go up to a certain dose, beyond which it causes undesirable side effects and activity. Carbamazepine. There are two important concepts of carbamazepine. One, carbamazepine as a byproduct produces 10-11 epoxide, which causes all side effects. But oxcarbamazepine does not produce 10-11 epoxide. Therefore, oxcarbamazepine scores over carbamazepine and now is a preferred drug as compared to carbamazepine. Second, carbamazepine induces its own metabolism, which is known as auto-induction. And therefore, for the first 2 to 4 weeks, what happens? It induces its own metabolism and the half-life keeps changing. Only after 4 weeks, it reaches a steady level. This has to be kept in mind, because since it induces its own metabolism, the activity becomes lessened. Only after 4 weeks, it reaches a steady state. So carbamazepine, it induces its own metabolism, known as auto-induction. Next, valproate. Valproate, as I said, has got many mechanisms of action, and therefore it's a broad spectrum epileptic drug. In fact, it can be used for other kinds of epilepsies like myoclonic epilepsy and absence seizures also. So sodium valproate is a wonderful broad spectrum anti-epileptic drug. And another important concept, as I said, when we use valproate and lamotrigine, they've done studies and they found that valproate and lamotrigine has got the best synergistic combination. Generally for epilepsy, the plan is monotherapy. Unlike other disorders like tuberculosis, where we give polytherapy so as to not bring out the drug resistance. But in epilepsy, we prefer monotherapy. In fact, monotherapy is the way we treat epilepsy. But sometimes when the epilepsy does not respond to single anti-epileptic drug, we have to go for 2 or more drugs. So when we use 2 or more drugs, they have found that, the studies have found that the 2 drugs, sodium valproate and lamotrigine, has got the best synergistic combination when compared to any other 2 anti-epileptic drugs. But as I said earlier, when we give lamotrigine along with sodium valproate, we have to be very careful and increase the dose of lamotrigine very slowly. Generally we increase every week, but here we increase every 2 weeks, because sodium valproate is a hepatic enzyme inhibiting drug, and therefore it does not metabolize lamotrigine fast, and therefore lamotrigine duration of action and half-life is prolonged, and therefore we have to reduce the dose of lamotrigine, particularly when we use with sodium valproate, because sodium valproate is a hepatic enzyme inhibiting drug. Benzodiazepines. Midazolam, lorazepam, diazepam. These are all 1,4-benzodiazepines, and therefore they are used only in acute management of seizures and status epilepticus. Diazepam, lorazepam, midazolam are 1,4-benzodiazepines, and therefore they are used only in acute management of seizures and status epilepticus. But clobazam is a 1,5-benzodiazepine, and therefore it can be used for long-term management. Even clonazepam can be used for long-term management. In fact, for myoclonic seizures, the drugs of choice are sodium valproate and clonazepam. So midazolam, lorazepam, diazepam are used only for acute management of seizures and status epilepticus, whereas clobazam and clonazepam can be used for long-term management. Another important concept of clobazam is that it's a wonderful drug, especially for intermittent therapy. There are few conditions where we need not give anti-epileptic drug on a continuous basis for a long term. Generally, when we initiate anti-epileptic drug therapy, like with phenytoin or carbamazepine or sodium valproate for any condition, generally it's on a continuous basis and for long term, 2 to 5 years, sometimes even lifetime. For example, juvenile myoclonic epilepsy, we give lifetime treatment. But there are few conditions where we need not give on a continuous basis for a long term. Only in that particular phase of epilepsy, if we give anti-epileptic therapy, that is sufficient. That is known as intermittent therapy. The classic examples are in children, febrile seizures. They do not get seizures on a continuous basis. Only when they get high fever, they throw seizures. Likewise, in women, catamenial epilepsy. Only some women, only during periods or during a particular phase of menstruation, they throw seizures, which is known as catamenial epilepsy. Third is the hot water epilepsy. Some people develop seizures only when they take hot water. So these are conditions where we need not give anti-epileptic drug on a continuous basis for a long term. We can give anti-epileptic drug only to in that particular phase of epilepsy. So one drug which really is useful for intermittent therapy is clobazam. So clobazam can be given when a child develops febrile seizures and then stop it. Likewise, in women, when she throws seizures in a particular phase of menstruation, give it and then stop it. Or hot water epilepsy, when the person is likely to develop seizures because of hot water, give clobazam and then stop it. So clobazam is a wonderful anti-epileptic drug which can be used for intermittent therapy. Right. Another important concept is that not all patients develop seizures or get status epilepticus when they admit in the hospital. So a lot of patients have seizures at their home or out of the hospital setting, and then they are brought to the hospital. So in that particular condition, pre-hospital setting, what is a good drug? We are not very much comfortable in giving IV lorazepam or IV diazepam out of hospital setting because they are all respiratory depressants and it may cause harm to the patient. So one drug which is really useful for persons having seizures in a pre-hospital setting is IM, intramuscular midazolam. So the trials have found that intramuscular midazolam, about 10 milligrams IM for adults, is very useful in the pre-hospital setting and has been proved by RAMPART trial. The rapid anticonvulsant medication prior to arrival time, according to this trial, RAMPART trial, IM midazolam is found to be very useful, intramuscular midazolam. Drugs, some anti-epileptic drugs we use for other conditions like topiramate. We use it for epilepsy or even for prevention of headache. Topiramate and zonizepide, another anti-epileptic drug, are prone to cause renal stones because of inhibition of carbonic anhydrase enzyme. So this also has to be kept in mind when we use topiramate or zonizepide. They have a tendency to cause renal stone because of carbonic anhydrase inhibition. Pregnancy. Suppose a pregnant lady develops epilepsy. What are the safe anti-epileptic drugs which can be given in a woman who is pregnant? The three drugs which are safe and can be given in pregnancy with epilepsy are levetiracetam, oxcarbamazepine and lamotrigine. Levetiracetam is emerging as a very popular drug because it has got no side effects and it has got the least teratogenic potential. So levetiracetam is a preferred anti-epileptic drug during pregnancy. The other safe anti-epileptic drugs which can be given in pregnant women are, other than levetiracetam, are lamotrigine and oxcarbamazepine. One anti-epileptic drug which is completely unsafe in pregnancy is sodium valproate. Because sodium valproate can cause neural tube defects, sodium valproate is better to be avoided in a pregnant woman with epilepsy. But in case there is no other option than using sodium valproate in a pregnant woman with epilepsy for a particular epileptic condition, then we have to use as low dose as possible of sodium valproate so as to not to develop teratogenic complications like neural tube defects, and we should always supplement with folic acid. Suppose the pregnant lady delivers a baby and starts breastfeeding in lactation. So what are the anti-epileptic drugs which are safe during lactation? Almost all anti-epileptic drugs are safe during lactation except probably phenobarbital, which is found in significant quantities in breast milk. Other than phenobarbital, all other anti-epileptics are safe. So as a physician, as a general physician, more so as a neurologist, we should know all these indispensable concepts of anti-epileptic therapy so as to approach a person with epilepsy confidently. I have enjoyed giving this lecture and I hope you have also enjoyed listening to my lecture. If you have any suggestions or comments, kindly post on to my YouTube channel. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.